Bismillah ar-Rahman ar-Rahim. Our lecture today will be about hypoparathyroidism. The objective of this lecture will be knowing the causes of hypoparathyroidism, what are the clinical features the patient may present with, and how to reach the diagnosis, and what are the laboratory findings that may be needed to do. What is the differential diagnosis? What are the differential diagnoses, and what is the treatment of such disease? Hypoparathyroidism, etiology. In the neonate, it may be due to the functional immaturity of parathyroid glands. Early neonatal hypocalcemia, it is common between 12 and 72 hours of life, especially in premature infants, infant with asphyxia, and infant of diabetic mother. There is what is called as late neonatal hypocalcemia, which occurs after the second to third day and during the first week of life, depending on the type of the feeding that's to be artificial. In both two cases, it may be related to the immaturity of the parathyroid glands and secretion of the parathyroid hormone. Regarding the causes, there is either parathyroid hormone deficiency, which occur in the form of aplasia or hypoplasia of parathyroid. There is what is called as DiGeorge syndromes, maternal diabetes mellitus, as we said, X-linked isolated hypoparathyroidism, and there may be suppression of neonatal parathyroid secretion due to the maternal hyperparathyroidism, or it may be inherited as autosomal dominant, or it may be an autoimmune parathyroiditis, or it is part of type 1 autoimmune polyendocrinopathy. In addition to these, there may be infiltrative disease lesions such as hemosiderosis related to the treatment of thalassemia, copper deposition as in Wilson disease. Other major cause is the surgical hypoparathyroidism, and usually it occurs iatrogenic either in total thyroidectomy or sometimes accidental during subtotal thyroidectomy. There is what is called as parathyroid receptor defect, the syndromes which are called pseudo-hypoparathyroidism, in which there is a defect, and there are two types, type A, 1A, and type 2, in which there is gonadotropin independent precursors of puberty in type 1A and type 1B. I mention this just to be aware about this item. Regarding the clinical manifestations, there is a spectrum of parathyroid deficiency with a clinical manifestation varying from no symptoms, that's asymptomatic, to those with complete and long-standing deficiency. Mild deficiency may be revealed only by appropriate laboratory studies when it is done for another purpose and found the patient to have hypocalcemia, hyperphosphatemia, and then diagnose the case as hypoparathyroidism. Some patients may present with muscular pains and cramps, which are an early manifestation. They may progress to numbness, stiffness, and tingling of the hands and feet. There may be only a positive gvostic signs. Gvostic signs, as you know, when you do tapping of the facial nerve in the parotid region, there will be twitching and deviation of the angle mouth due to the stimulation. This is an early signs for the latent hypocalcemia. Another signs for latent hypocalcemia is what is called Trozius sign. In Trozius signs, the blood pressure curve is inflated to 20 mm mercury above systolic blood pressure level. Arterial blood flow to the hands is occluded for 3 to 5 minutes. Then the patient will develop carbopetal spasm, in which there is a flexion of the wrist, a flexion of the metacarbophalangeal joint, extension of the interphalangeal joint, and there is adduction of the thumb and the finger. And this is what is called as a carbopetal spasm, which can be induced by Trozius signs, or the patient may present with carbopetal spasm when there is severe deficiency of the parathyroid gland and the patient parathyroid gland hormones, and the patient had hypocalcemia. Deficiency of parathyroid glands or parathyroid hormone, there may be carbobedal spasm and sometimes laryngeal spasm, and the patient may present with croup. Convulsion with or without loss of consciousness may occur at the interval of days, weeks, or months. These episodes may begin with abdominal pain followed by tonic rigidity, retraction of the head, and cyanosis. So, hypoparathyroidism is frequently mistaken for epilepsy, and we have several cases with other colleagues. They are diagnosed as a case of epilepsy, and when do the investigation for them prove to be hypoparathyroidism, and then we stop anti-epileptic drugs. Headache, vomiting, increased intracranial pressures, and bubble edema may be associated with convulsion and may be suggest a brain tumor. In patients with long-standing hypocalcemia, the teeth erupt late and irregularly and may be unusually soft. Mucocutaneous candidiasis, when present, antedate the development of hypoparathyroidism. This candidal infection most often involves the nails and the oral mucosa and the angle of the mouth, and less often the skin. It is difficult to treat. Cataract in patients with long-standing untreated disease are a direct consequences of hypoparathyroidism, so estimation of the calcium and diagnosis of hypocalcemia, it should be done for every patient with cataract, especially when he is of young age group. Manifestation of Addison disease, lymphocytic thyroiditis, pernicious anemia, alopecia areata or totalis, hepatitis, and primary gonadal insufficiency may also be associated with those of hypoparathyroidism. This indicates an autoimmune process, and this is what is called as polyendocrinopathy type 1. So it could be one of the part of the polyendocrinopathy type 1. The patient present for the first time with mucocutaneous candidiasis, and then patient present with carbobedal spasm and hypoparathyroidism, and later on he may develop Addison disease or other part of this polyendocrinopathy. Permanent physical and mental deterioration occur if initiation of treatment is delayed. What are the laboratory findings? These are very important, and it comes in exam or in the MCQ. Serum calcium is usually low, 5 to 7 mg per deciliter. Blood level of ionized calcium, which is usually approximately 45% of the total, are low. Serum phosphorus elevated, 7 to 12 mg per deciliter. So there is hypocalcemia, hyperphosphatemia. Serum alkaline phosphatase is normal or low, and this differentiate cases of renal failure in which also there is hypocalcemia, hyperphosphatemia, but the alkaline phosphatase is high in case of renal failure, while it is a normal or low in the case of hypoparathyroidism. Estimation of the vitamin D level is usually low, but high levels have been found in some children with severe hypocalcemia as compensatory mechanism. Serum magnesium is normal, and it should be always be checked in hypocalcemic patients, especially when they are not responding to calcium infusion. Level of parathyroid hormone are low, and when measured by the immunometric assay. Radiograph of the bone occasionally reveal an increased density limited to the metaphysis, suggestive of heavy metal poisoning. It is limited to the metaphysis, not to the epiphysis, as in the case of ricket. X-ray, skull X-ray or CT scan may reveal calcification in the basal ganglia. ECG, there is prolongation of the QT interval due to the hypocalcemia, which disappears when hypocalcemia is corrected. EEG, this is very important. It reveals widespread slow activity. The tracing return to normal after the serum calcium concentration has been within the normal range for a few weeks, unless irreversible brain damage has occurred or unless the parathyroid insufficiency is associated with epilepsy. So it returned back to normal. So it is better to do an EEG when there is a suspicion of, when there is case of hypocalcemia. It is better to repeat or to do the EEG only in a patient with a present with convulsion only after correction of the hypocalcemia. And then we can repeat the EEG because it may be mistaken as a case of epilepsy. Regarding the treatment, emergency treatment of neonatal tetany consists of intravenous injection of 5 to 10 ml of 10% solution of calcium gluconate at a rate of 0.5 to 1 ml per minute, while the heart rate is monitored. Older children, we use IV calcium gluconate in a dose of 1 ml per kg per dose until the spasm relieved, and then the dose reduced to 0.5 ml per kg per dose every 6 to 8 hours. In addition to that, active vitamin D, that's to say 125 dihydroxycholecalciferol, calcitriol, should be given. The initial dose is 0.25 microgram per 24 hours. The maintenance dose range from 0.01 ila 0.1 microgram per kg per day. The advantage of calcitriol, it has a short half-life and should be given in 2 equal divided dosage. And it has a rapid onset of effect, that's to say 1 to 4 days, and a rapid reversal of hypocalcemia after discontinuation in the event of overdosage. Calcium level will fall within in 3 to 4 days. Calcitriol is supplied as an oral solution or in a form of tab. In addition to that, an adequate intake of calcium should be ensured. Supplemental calcium can be given in the form of calcium gluconate or calcium glubionate to provide 100 mg of elemental calcium daily, but this is rarely essential. Sometimes we use calcium carbonate tab as a phosphate binding agent, not as a calcium supplement. And once the phosphorus decline, the calcium will be elevated. Food with high phosphorus content, such as milk, eggs, cheese, and dairy products, should be reduced in the diet, although they are a good source for calcium, but they contain a high phosphorus content, so it should be reduced in the diet. Clinical evaluation of the patient and the frequent determination of the serum calcium are indicated in the early stage of a treatment to determine the requirements for the calcitriol or vitamin D2. If hypercalcemia occurs, therapy should be discontinued and resumed at a lower dose after the serum calcium level has returned to normal, and this is essential to avoid the side effect of hypercalcemia. When the patient develops skin pigmentation with lowering of blood pressure or weight loss, this may indicate adrenal insufficiency, which may require specific treatment, and this could be a part of polyneuropathy type 1 and should be kept in mind when treating a patient with hypoparathyroidism during follow-up. Regarding the differential diagnosis, magnesium deficiency must be considered in a patient with unexplained hypocalcemia, especially when they are not responding to the IV calcium infusion. Concentration of serum magnesium less than 1.5 mg per deciliter are usually abnormal. Causes: either familial hypomagnesemia with secondary hypocalcemia, or sometimes hypomagnesemia may occur in malabsorption syndrome such as Crohn's disease or cystic fibrosis. Patients with autoimmune polyglandular disease type 1 and hypoparathyroidism may also have concurrent steatorrhea and low magnesium levels. Therapy with aminoglycosides may cause hypomagnesemia by increasing urinary loss. It is not clear how low levels of magnesium lead to hypocalcemia. Evidence suggests that hypomagnesemia impairs the release of parathyroid hormone and induces resistance to the effect of the hormone. There is what is called a pseudo-hypoparathyroidism, Albright hereditary osteodystrophy, in which the patient had the parathyroid glands are normal or hyperplastic and they can synthesize and secrete parathyroid hormones. Serum levels of immunoreactive parathyroid hormone are elevated even when the patient is hypocalcemic, and may be elevated when the patient is normocalcemic. Neither endogenous nor administered parathyroid hormone raises the serum level of calcium or lowers the level of the phosphorus. The genetic defect is in the hormone receptor adenylate cyclase system, and usually are classified in different various types depending on the phenotype and biochemical findings. So the patient may present with specific anatomic stigmata, short stature, with dimpling shortening of the fourth metacarpal bones, and some other features. There is another entity, what is called a pseudo-hypoparathyroidism. Some affected members may have the usual anatomic stigmata of pseudo-hypoparathyroidism, but serum level of calcium and phosphorus are normal. However, parathyroid levels may be slightly elevated. So the patient may have a stigmata of pseudo-hypoparathyroidism, but it does not have hypocalcemia or hyperphosphatemia and need no treatment. And I have two cases as such from Jalawla in Diyala. They consult our clinic for the diagnosis of hypoparathyroidism, but proved to be a pseudo-hypoparathyroidism. Thank you very much.